So just to give a brief introduction to Martin. Martin is the head of product for Unboxed, and he's going to be speaking about creating a MVP for the NHS service. And he also has co-presenting with him is Melanie Martin, who's gone therapy practitioner in dermatology. So a huge welcome to you both. And I'm just going to go ahead and mute everyone. So I'll leave it to you. Guys, the chat box is open. So if there's any questions, bomb some chats, some questions on the chat box there. Also, the Twitter, if you want to, the hashtag is UXH2020 or UX Healthcare. And we're also going to be giving away quite a bit of free tickets for our Amsterdam event happening at June the 2nd. So welcome, Martin and Melanie. I'll leave it to you.
I hope everyone can hear me okay. I'm just going to do a quick check. Mel, are you able to say hello as well?
Yes, good morning, everyone. Can you hear me?
Thanks, Mel. I can hear you, so I'm assuming everyone else can.
I can hear you as well.
Great. Hi, Theo.
Excellent.
Hey, Mel.
Thank you. So good morning, everyone. As Theo said, my name is Martin Evans, and I'm head of products at Unboxed. We're a service design and digital product development company who work largely, but not exclusively, in the public sector. A couple of things we've done in the past. We're responsible for the UK parliamentary petitions online service, which some of you in the UK will have used. We're currently building a new back office planning system to increase transparency in the planning process in the UK, which will be used by local authorities across the UK. And in healthcare, we help develop an award-winning online sexual health service called SH24, which some of you might have heard of. Today, we're going to talk about a digital service we've developed with Guy's and St Thomas's NHS Foundation Trust. I'll give you a little bit of background to the project and tell you mostly about our approach before handing over to Mel, she's what we call the clinical product owner of the service, and she's going to tell you about the evaluation work that she's currently doing and the impact the service is having. Inevitably, she'll also talk a little bit about COVID and the potential of our system to help the Trust recover from that current crisis. The remote monitoring program project emerged from a program of work which was conducted back in 2017, actually. Some of you may have heard me speak at this conference in the past about that. And the program was to introduce concepts of design thinking, some lean startup, and some agile principles to teams in the outpatients department of the Trust of Guy's and St Thomas's, known as the Specialist Ambulatory Services. So within the hospital staff, there was a general frustration at the lack of progress, the lack of real change being made by various transformation and improvement programs at the Trust level. And it was felt that ultimately many patients were being let down by the service. There was enough knowledge in the teams, and there were individuals who had the will to make a difference, but what they needed was the time and the space, and to a certain extent permission and some external support to make this change happen. Over a period of about 6 months or so, we conducted a number of workshops with service managers and clinicians, so doctors, nurses, and other related health professionals. The workshops were designed to create a better understanding of patient needs, and also to map out existing patient pathways and identify pain points and blockers and obstacles. And we did this across multiple services, including cancer, dermatology, allergy, genetics, sexual health, and others, including rheumatology, which we'll talk in more depth about. But what became apparent very quickly was that everybody already knew very well what the problems were, and had largely come to the conclusion that that's kind of the way things are. It's just the way it is. And we found these workshops were kind of like a group therapy session. We just set the context, answered a few kind of key probing questions and let the emotions flow. But we got some great insights from these workshops. Whilst we encourage people in a kind of design thinking sense to stay in the problem space for as long as possible, inevitably there were lots of ideas and opinions on how things could and should be improved, which we diligently captured on post-it notes, as is our way. But what we found was that the proposed solutions were often, they were so framed by the existing constraints, some kind of cultural constraints, behavioral constraints. Lots of them were technological constraints, and some of them were just kind of, frankly, ridiculous, habitual behaviors. So what we encouraged teams to do was to think beyond the limitations of the current services, their current experience, especially the many technological constraints that they encountered on a day-to-day basis, and rather imagine what the service may look like if it was entirely focused on delivering maximum value to patients, and could be run on a digital technology stack that could work exactly as they needed it to do. In essence, what we heard was that there was an awful lot of waste in the system, specifically wasted time, I think. Clinicians would spend far too much time wrestling with multiple poorly designed IT systems that were rarely connected to each other. Information that they were looking for was incomplete and presented inconsistently. And communication between the hospital and the patient, in a world where we're also familiar with email, SMS messaging and social media channels, communication was still largely dependent on letters sent through the post, but also they were also the single source of truth within the clinical systems was stored in these letters, PDF format. Patients' time is also wasted. They're often traveling to hospital to attend appointments that weren't really needed, and waiting around at the hospital for much longer than they should, filling in forms that weren't even looked at, having tests done that may or may not be necessary, and then waiting too long to receive the results. They were generally receiving a service that they would find unacceptable if they were paying for it, which of course in a sense they are, and we all are paying for the NHS service. So having conducted these workshops across a number of services and talked to patients about their experiences, we were able to see some recurring themes, some really important problems, which if we could solve in one service, working closely with the service team, would provide a pattern to explore in multiple services across the whole of our outpatients. One of these themes was that this problem of unnecessary appointments, which is kind of described on the screen now, and the inverse problem of unnecessary appointments. We'll talk a bit more about what we mean by unnecessary, but the inverse problem of not being able to get an appointment when you really need it. We'd explored a couple of the different services within rheumatology, and we'd been working with the lead clinician in that department, so we decided to look more closely there. Whilst there's a very strong business case to fix the problem of unnecessary appointments, there's a financial driver for the hospitals, which we won't go into now. Much more importantly, there are very sound clinical reasons why the hospital should make better use of these scarce appointments. If you take patients with a condition such as rheumatoid arthritis, this is a long-term condition which can be managed very effectively with some pretty serious medication. And patients with low disease activity or in a state of remission, aside from regular blood tests to make sure the medications aren't having any adverse effects on them, they're largely left to it, except they're just left to get on with it, except for a few periodic check-ins with the hospital, maybe every year or every 6 months. It's part of the process that's prescribed. However, if their condition flares, their condition becomes active in the interim period, they find it really difficult to get help at that point in time. So they call the hospital, they navigate automated telephone systems, they go to a GP and even end up in A&E departments, all of which end up in delays in getting the specialist care that the hospital is there to provide. And delay in treatment has serious implications for their long-term health. From a patient perspective, things often seem quite different. Most patients don't really see appointments as unnecessary for various reasons. Those who are in a stable condition sometimes feel it's important to keep their regular appointments, even if it's just to make sure they don't get discharged, they don't fall out of the system, as this patient says here. Other patients are reluctant to engage with the hospital between visits, even when they are in flare, either because they feel they can't be helped, or in some cases where, other patients need the appointments more than them. Other patients are really well and feel like they just want to get on with their lives without being reminded that they're ill. On the whole, patients are really sympathetic to the NHS being stretched, and are very open to the idea of releasing their appointments for others who need them more. So based on the insights we've gathered from multiple stakeholders and users, including clinical teams and patients, we formulated two hypotheses, and I mean these hypotheses in a looser sense, these aren't scientific, just some assumptions, some ideas that we had. Hypothesis one is based on the assumption if we could create a new channel of communication between the hospital and patients, both patients and clinicians would feel more confident that face-to-face appointments were not always necessary, and that patients would be able to get help when they needed it. Hypothesis two was around the use of something called patient-reported outcome measures, or PROMs. Now, PROMs capture disease-specific parameters from a patient's perspective, and they have huge potential to improve the quality of care the patient receives, but they are used inconsistently, and patients actually see little value in using them. So our second hypothesis was that by integrating PROMs usage into patient care, they could be used to monitor the condition and to modify their care accordingly. So our initial solution, our idea, consisted of a two-way SMS communication service between the patient and the hospital, a simple online PROM form, in this case something called the RAID form, which is specifically for rheumatoid arthritis, and a simple clinical interface by which we could test these two hypotheses. In 2018, we received some funding from the Guy's and St Thomas's charity to address this issue, and in 2 or 3 months at the end of the year, we developed an MVP, a minimum viable product, to support the delivery of this new service in rheumatology. With a combined digital team from Unboxed and a clinical team from Guy's and St Thomas's, largely based on site at the hospital, we ran an agile design and development process over 7 2-week sprints to design, test, and build the remote monitoring service. Features of the new service were prioritized based on effort, value, risk, uncertainty, and delivered iteratively throughout these 7 sprints. With our first 5 patients being onboarded at that point at EC MVP Live, we had 5 patients actually start using the system at that point. The reason Sprint 4 is stretched like that is because of the Christmas period. Patients and clinicians were engaged constantly throughout each sprint to either test prototype designs or gather feedback on what we were developing. But the most valuable insight, as it always does, came from those first live patients as they started to use the system in the wild, as it were. Every sprint, so every 2 weeks, we ran an open show and tell for the entire rheumatology department. where we shared progress and shared our learnings. And these sessions were extremely effective in getting buy-in from the clinical teams. We were able to demonstrate that their feedback could be interpreted and integrated into the development process, and that technology could actually be used to start to transform the service they were delivering. A good illustration of this process is the way in which clinicians' concerns about the additional demand that the new service may place on their time, and also the potential risk of opening new channels of communication with the patients. When we tested the PROM form prototype, the PROM is a sliding scale, numerical scale. Patients requested a free text box at the end of the PROM form so that they could provide more context to these numerical PROM scores, and clinicians were very resistant to this idea. But as I say, we got some patients on board, and after the first few PROMs were submitted, we found that the clinicians were not just reassured that there wasn't a risk, but that actually this feature added a great deal of value to the service. Interestingly, we also found that patients were quite reluctant to use the SMS service. They didn't think it was a thing they could do, was send an SMS to the clinicians, which is the exact opposite of what the clinicians feared, which was this kind of flood of incoming requests. Over the next few months, we slowly recruited more patients to the platform. We set ourselves a target of about 100 patients for a trial period of 6 months to a year. And Mel's going to give you some more insight into the effectiveness and impact. But before I hand over to Mel, I just wanted to share something else. From the start of the project, I was of the opinion that by creating this simple system to open up communication channels between the patient and the hospital, and demonstrating the fact that technology could be developed within the hospital itself, so co-designed with clinical staff and to a certain extent patients, that many new opportunities would open up to solve different problems within the outpatient service. And this proved to be the case when we were approached by a pharmaceutical company who gave us some money to explore the problem of routine blood monitoring for our cohort of patients. Now, blood monitoring is essential for patients on biologic medication, and it's a notoriously unreliable process with blood tests often missed and repeat prescriptions being delayed. Having already developed a scheduling and delivery of PROM reminders via SMS, we were quickly able to extend this to automatically send blood test reminders, and then develop it to automatically process the blood test results as they came in. Whilst the challenges of integration with hospital systems still remained, this is a system that has great potential to not just improve the patient experience, but also their health outcomes, again, without face-to-face contact. The work on blood monitoring also gave us it kind of facilitated and enabled the development of a flagging system in the system. Irregular blood tests were automatically flagged for the attention of a clinician, and we were able to extend that to PROMs, so we could start to flag PROM scores that may indicate patients were in flare or who were struggling to cope mentally with their condition. And the potential of this is enormous. I'm going to hand over to Mel now, who will talk to you a little bit more about this ongoing evaluation and how we intend to expand it in the future. Mel, over to you. If you can.
Thank you very much, Martin, for the introduction. Can I just confirm you can hear me?
I can hear you, so I assume everyone else can.
Great, thank you. And as Martin said, I am the clinical product owner for the remote monitoring service within rheumatology at Guy's and St Thomas's. And Martin has more than set the scene. He's told a story of our collaboration, and it is very much a collaboration between a clinical and a design team. Two groups of individuals who speak a different language, but over the course of 18 months have really become to speak as one. So I've had two very busy roles in the rheumatology service at Guy's. One as an advanced physiotherapy practitioner, and the other as the clinical product owner. And I'm going to abbreviate it to CPO, as us healthcare workers often do. So as the CPO, some of the challenges which Martin has already raised have been to balance the delivery of value through good service design, in this case, to two user groups, that's patients and clinicians. So as CPO, I have needed to really continue to own the vision and high-level ambitions for this service throughout the role and the smooth. And when you're aiming for the win-win-win situation here, for patients and clinicians, as well as enacting the ambitions for the long-term plan, it can only come from thinking big and leading the sustainable change we know it needs. So you need to keep an unwavering focus on what the problem is you're trying to solve and who you're trying to solve the problem for. Knowing what to build for whom and what's important about what not to build and when. And that role has been mine to share and provide just enough information for the design team, estimate and deliver the work that's being required. So taking the role of the product owner really has been the most inspiring and empowering role I've had in 23 years in the NHS. And it is that because it's been a collaborative, cross-functional team effort. Next slide, please, Martin. So as Martin said, I'm going to speak for the next few minutes about evaluation. And through continuous feedback via waiting room interviews and unsolicited comments from the service users, we felt justified in our focus on user interface and the user's experience of the messaging system. We were getting a great deal of really invaluable feedback about not only the usability of the tool itself, and bearing in mind these are rheumatoid arthritis patients, a broad age spectrum, some of which may have manual dexterity challenges because of their established disease. So whilst we were confident in the tool, we needed to understand these key aspects. And so evaluation was planned from the get-go. But like any service design process iterates, so too has our evaluation. The key metrics we remained focused on were patient engagement, governance, and that's clinical and information governance, and then clinical outcomes, and risk falls within governance aspects. Next slide, please. So we aimed for 100 patients. I mean, this evaluation covers from January last year to the end of March this year. We've actually had 129 patients enrolled to the service. We've had a really high level of engagement from these users. 86% have engaged with the service, and nearly 70% of them have completed more than half of the prompts that have been sent to them on a monthly basis. 35% have completed all of the prompts, enabling us to see a very clear picture forming of their disease activity. And that's a view that they also have. You'll see on the icons of the mobile phones, that's the view of the user. And on completion, they get a graph of their last few months completion. And it enables them to build a picture up in their minds of how they really have been doing, what might have triggered some spikes, and what helped them stay nice and low and smooth on those graphs. All services need to be iterated upon in their live state. And we needed to nudge a few patients along the way with a text message to invite them back and to reinforce what we felt was the value to them. And that was a very effective way. With most of the people who we nudged, they completed their very next month from. The opt-out rate perhaps wasn't a surprise. It was a total of 16 or 17 patients, I think, over time. But they didn't opt out immediately. All but 4 of them have responded to the service and engaged at some point. Next slide, please. So you can see that our engagement level was fairly consistently between sort of 65–70%. It was higher in the early months because these patients had been recruited from the waiting room and had actually been involved in those first iterations of the user interface itself. And at month 4, or in April of that year, we moved to an opt-out recruitment model where patients who were identified by clinicians on discussion with them to be suitable for remote monitoring, that were in low or disease remission state, had a mobile phone, who had read some information about it and liked the idea, they came on board. And it was from that point we seemed to have a very consistent response rate. We were always interested in trying to get that red box down and understand how we can increase engagement levels. Next slide, please. So as I said, governance is really, really important to engage with, think and engage with from the very, very beginning to ensure the pace of the project. We had early engagement with the information governance lead at our trust, who was very, very supportive. And it was new. It was a new project for them to learn with us. The important questions of what's data, who, and how people have access to the data evolved as the service did. So constant sort of iteration and interaction of the DPIA, the Data Protection Impact Assessment, ensured that the technical assurance as well as the information assurance was never beyond critique. It was important to be our focus. And so patients have the opportunity to click upon a why do this really button icon on the screen there, and it takes them to a brief summary document about who is going to see their data, why we're collecting it, or what value to them. So hopefully we're on the clinical risk slide. So the other important aspect of governance, of course, clinical governance, is about managing risk within the remote monitoring service. Concerns had previously been highlighted with other remote care models in rheumatology, and an example of a transformative model of outpatient care is patient-initiated follow-up, which was trialled in the mid-2000s in Bristol, again with the rheumatoid arthritis population. And the concerns that were generated from that model were focused around patients not engaging and asking for help when they needed it most. And I think it's important to say that the remote monitoring service has offered remote care complementary to the usual care they receive from us. However, it is a long-term service ambition that we would be able to offer safe deferment appointments, or indeed moving to a patient-initiated follow-up model to enact the transformation of care proposed sort of within the long-term plan. So we really want to build that trust and confidence in our service in managing risk. So it's been really important to build confidence with clinicians, to trust the service, and to make sure that we have a high level of consensus, of agreement in the decision-making around which patients should receive a text message back from the service and be invited in to interact with the service, and those who we can simply acknowledge and say, see you next month, virtually, remotely. So the service has been concierged by me, and I am a clinician. However, I'm not a rheumatologist. I'm a physiotherapist practitioner. So it's been important to ensure that clinicians' feedback about the decisions made by myself as the concierge or the dashboard are fed back into the sort of operating procedures for the service. Because we have a future ambition, and it's an ambition that is soon to be enacted, to have a digital pathway coordinator, someone who is not a clinician, who will concierge the service, and to ensure that there is appropriate and timely two-way SMS communication between patients. I am going to talk about COVID, as Martin said, but I think it's important at this point to acknowledge this comment from this patient. I would definitely think about not coming to an appointment if things were nice and stable. Travel a fair distance. I don't want to waste anyone's time. I know how busy everyone is. Well, Martin alluded to this sensitivity that patients have towards the NHS and recognising that we're very busy. This is pre-COVID, of course, that our services were certainly taking a great deal of strain. So I think when we talk about appointment deferment, it's a supported decision, and it's a shared decision that the remote monitoring service supports. Next page, clinical outcomes. Okay, so this is a really interesting part as a clinician, because what I want to know is, are our patients doing well outside of hospital? And what we can say with some examples here is those patients who present to the service in low disease or remission state of disease activity, who then are onboarded onto the remote monitoring service. A great deal of them then stay within that low disease activity or remission range. And 25% is a great deal of outpatient follow-up appointments that we could be looking to defer or deliver in a different way, non-face-to-face. And actually, this is an important message that the tool itself, the RAID, the Rheumatoid Arthritis Impact Disease tool, is actually sensitive to detecting the change in disease state. So we also identified that patients who were using the remote monitoring service largely were doing so appropriately. They were making contact remotely and using our telephone advice service. And that's when treatment was being escalated appropriately and changes of clinical management made that, as Martin said, need to be made at the right time, the right patient. And so the service was not being inundated and has continued to not be inundated by inappropriate and super users, as we might think about that term. But we need to understand PROMs. Whilst they're not new to rheumatology practice, capturing them remotely is. And so understanding what they mean to both clinicians and patients is really important. So not every significant increase in a PROM resulted in contact. Next slide, please, Martin. I'm on to understanding PROMs from patients now, because I've noticed the time. Patients' perspective. There was a clear recognition by patients that appointments can be directly associated with PROM scores, and that value was placed on knowing that PROMs would be reviewed before the next appointment. And I think that's really important. In the past, we know they haven't made it onto the system. They haven't made it into the clinic room when the patient's been present. They've been hurriedly completed in the waiting room, not much thought or time given to those responses. This service is built around those responses, and so it is absolutely important that the clinicians engage with the patient using them. So a good percentage of patients believe that access to care, next slide, Martin, you with me?
Yeah.
Sorry. 72% of patients believe that access to care has been made easier through the provision of remote monitoring. And that's a very, very important headline here, because we've heard of the struggles of re-entering that unpenetrable system at times for some patients. Okay, very last but certainly not least, in the wake of COVID-19, we have seen accelerated change in the NHS that I have never seen before and may not see again in my 23 years so far. And in rheumatology, that means a significant backlog of routine follow-up appointments that we need to manage. Next slide, please. So the proposal here is, so what we did with the remote monitoring service is we used it well. We engaged patients who had contacted the service and solicited about a matter or maybe a medication issue, maybe a flare. We offered them the remote monitoring service, and of those 18 patients that we recruited during lockdown, all but one of them responded immediately and completed their PROMs. We created rapidly an SMS template library where we were able to send out guidance about the latest medication advice. Those people that were self-isolating or shielding exercise resources, things to do at home, but also paying important attention to people's emotional well-being. And that quote there really does highlight the stress that our patients have understandably been under. So we used the service and evolved it very, very quickly for the situation we found ourselves in. Last slide, please, Martin. So the future. So I believe the future is very bright for remote monitoring. In fact, I believe remote monitoring is the future for not just rheumatology, but a large number of our chronic long-term condition populations. We do have the opportunity to build upon our existing platform, our existing learning, to expand to other conditions within rheumatology. But we have already begun to make progress with expanding this service model across the integrated care system of South East London to share with our rheumatology partners, and also across and within the trust with other areas where the blood monitoring is a heavy burden for clinicians. And whilst we are moving towards restoration and recovery of outpatients, as this headline from this morning's news raised, we are still keeping our eye on the long-term plan for the NHS. And that's where I believe remote monitoring is here to stay. Thanks very much for listening.
Thanks, Mel. Theo, over to you.
Thank you very much, Melanie. That was, I don't know if you can hear me. Thank you, Mel. Thank you, Martin. We just have time. Our session, next session starts in about 2 minutes, but we have one question here from Valentine. I don't know who's going to answer it. So I'll just leave it up to you guys. But the question is, do you think that SMS would be also recommended as to a native app, which can have also a built, I would assume it's built-in notification system?
Yeah, we deliberately went with SMS because we wanted for this MVP to reduce all barriers to entry, or as many barriers as we possibly could. So we decided to go with a simple mobile web interface for the PROM form and SMS as the channel of communication. There are many apps out there actually for people to monitor their arthritic conditions or other conditions, but they're not widely used, and no one in the clinical team has ever had anyone come to them with one of those native mobile apps and say, look at my condition. They tend not to be used, not to be connected to hospital systems. So we wanted to move quickly, and we wanted it to make it as accessible as possible. For example, we don't even have a login for the patient at the moment. They're sent a kind of one time, or there's a link to a PROM form that lasts for a month, and we don't reveal any personal information. So they don't need to log in. They can do it very simply. It's one click, and then they can enter the detail. The only thing they see is a graph of anonymous information over time when they've completed their PROM. So it was really just about reducing barriers. We didn't want people to have to download a native app. In the future, may well be an option, especially if we think about integrating the NHS app or something like that.
Okay. Valentine says thank you. There's actually way more questions. I'm going to read one more question for you, Martin and Melanie. If you guys can hang around and go into the chat, there's more questions on the chat there. But I have a question here from Rahul, and Rahul, thank you for asking the question. He's saying, his question is how to deal with the big amount of patients and clinicians' personas. Some of them are digital friendly. Some of them are more flexible. Some are attached to their old modus operandi. So how to cover all of that?
Do you want to take that one, Mel?
Yeah, I think if we talk about the rheumatology population, we recognise that within the M25 of London, around London, 99%, or I think it's 98 point something percent, have use of a smartphone. So we recognise there are margins of our patient population, who may not wish to or be feel able to interact in this way with our service. And I think it's really important to recognise that we built the SMS service alongside both an existing email service and a telephone advice service. And it was very, very important to be able to offer the choice of communication. But we were responding to, feedback. We were responding to the need from our patients for more information, more timely response, more timely care. So SMS was very popular to our patient group, whilst recognising that those margins of our patient groups, we need to make sure we continue to offer equitable service accessibility. And so by continuing to offer the telephone, email, and of course face-to-face consultations, we have had and the users are a broad age spectrum.